right, we're going to keep moving. That was a fast transition, so congratulations, everybody, at almost 4 o'clock that we are on the ball that much. So we are moving into our public policy discussion. So as you can see in looking at your agenda, we have grouped public policy, philanthropy, and then payer pilot projects together, kind of think of it as a funnel in terms of like we're working down from, payment all the way down to how things actually kind of meld together and work at a community level. Our panel today is going to discuss some of the policy levers that could assist in kind of moving the work forward, and I'm going to let each of them introduce themselves quickly here, starting with Lauran.
Test. Okay. I'm Lauran Larson. I'm the lead wellness coordinator at
Let's just trade it out. It's okay. No worries.
We can share.
You can share.
Good afternoon, everybody. I'm Katie Sawyer. I'm State Director for U.S. Senator Roger Marshall for the state of Kansas.
And hello, friends. I'm Trina Ragain. I am the President and Chief Eccentric at Eccentricity Consulting.
All right, well, thanks for the introductions. We're going to start like we did in our last panel and give everyone just a few moments to kind of lay out some points that they think are important in this discussion, and we're going to let Lauran go first since she has some pressing commitments soon.
Yes. So, whoa, that's way loud. Sorry. So I do work for state government. You're probably wondering why I'm here. I'm not a researcher. I'm not a food as medicine practitioner. I think of myself as a connector, but I actually oversee our physical activity and nutrition team. And if you look at what the CDC says that a state physical activity and nutrition team should be working on, it's a lot of those policy-based approaches. It's a lot of those upstream approaches. So we did establish a state obesity prevention plan a couple of years ago, and we have a lot of objectives in that plan that relate to food insecurity, nutrition insecurity. And so this whole concept of food as medicine has been growing. About a year and a half ago, if you asked me what an 1115 waiver was, I would have just looked at you like you're crazy. But I've been learning, and one of those things that the CDC suggests that you work on is trying to get one of those 1115 waivers. And so we've been trying to build momentum for that. We met with some partners, and then we saw this amazing technical assistance opportunity in the summer through Harvard Center for Health Law and Policy Innovation. And we teamed up with one of our biggest advocates in our state. We have a few amazing current GusNIP grantees. We have a couple produce prescription grantees, and the largest nutrition incentive GusNIP grantee in the state. That's Hunger Free Oklahoma. And I'm in the country, not the state. Anyway, so we teamed up with one of those GusNIP grantees. That's FreshRx out of Tulsa. We wrote for this technical assistance opportunity, and we are one of 2 states that received it. The other state is Alaska. So we formed a food as medicine coalition. I think we have over 80 stakeholders now on that coalition. But the coolest thing is that we have our Medicaid agency on our core team with Harvard. And so every single month we're meeting one-on-one with the Harvard team, these experts in health law and policy and all of this, and healthcare authorities right there with us. And this GusNIP grantee is right there with us. And so we're getting all of this expert guidance on how to even pursue the Medicaid 1115 waiver. Hope that answered your question.
Yeah, that's great. Katie, moving to you, and you talked a little bit for those that were here yesterday about kind of some of the broad overview of the current landscape of some of the active policy that could support some of this. Kind of zooming out a little bit as someone who works with the senator closely and a senator that's very involved in this work in Congress, when he's, looking at these various issues and considering support or, development of legislation, what are some of those key components? I know when he was back in Kansas this summer and we did a site visit related to food as medicine, he was really taken with what we would consider the qualitative data components related to that. And so maybe talk a little bit kind of about how he approaches legislation or development of that or the support of that.
So the senator, as Brandon said, is very involved in the food as medicine because he comes from a medical background. And then, of course, being an ag state, we get both sides of it, and we have seats on committees of jurisdiction for both. Where the senator, where I play a role in helping the senator develop policy is I'm not on his policy team, but I try to act as the conduit between the people on the ground doing the work in the state of Kansas and the policy team in DC. The policy team is concerned with rules and regulations and facts and data, and that's what they have to accurately write legislation. What I'm concerned with here on the ground is telling the story and putting the faces to the programs that we are trying to create or improve. So, when we sat down at Matthew's facility in Newton this summer, he was concerned with the qualitative data. We also learned a lot about hey, we give these people this food, but they don't actually have the infrastructure within their homes to cook the food. And so, it's things like that when you're talking about big picture policy, you're looking at a lot of really high level, big picture stuff about how does this work with this agency and this program, but you forget about a lot of the day in, day out application of those programs on the ground. And so one of my goals and one of my job responsibilities is when he's back in the state, I show him how the policies are working in Kansas, or sometimes not working in Kansas. And so, when all of you are working to advocate for different programs, policies, or even maybe changes to existing policies, one of the things I always encourage is tell your story and reach out to your state, local, state, federal, whatever level you need to be interacting with, and encourage them to come see what you're doing and come see how it's working or maybe not working, because those stories are what the senator or any elected official is going to be able and want to go back to their peers and tell the stories. And so, as I mentioned yesterday, the senator is working on a food as medicine hearing in the HELP committee coming up this spring. What he's going to need is he's going to need to find people in Kansas who he can bring up, set in front of fellow committee members, and accurately tell the story of what's going on. And so it's my responsibility to make sure he knows who those actors are in the state and he knows who's implementing the programs and who can speak about those programs. And so the more interaction we get with the programs and the people who know them, and not the high level data, that's necessary, but just the practical day in, day out people who are doing the nuts and bolts work, that's really important. And that really speaks a lot to the senator and tells him, yes, this is working, or no, this is not hitting the note, and so we need to try again when we're crafting policy. And in a state that is far removed from Washington, D.C., in population and in location and all of the above, we have to work extra hard to make sure what they're drafting in D.C. works in states like Oklahoma and like Kansas. We have a rural population. We have lack of access to food systems in some of our states. So we have some barriers that D.C. doesn't always think about, and senators from other states aren't thinking about.
Stay with you for just a second here. So during that legislative process, clearly the senator has a lot of interest and support for bills that fall into this category. What is the general pushback from those who aren't as supportive? What do we tend to hear in terms of what's some of the things that derail what we think would be quality legislation to support this space?
For a lot of it, I think it's the technical nature of not understanding what this is about. When you get into the weeds, as you referenced, on some of these pieces of policy and you're dealing with multiple agencies and you got to get waivers for stuff, you start talking to members, and if they don't have people on their policy teams who know the language and are willing to or willing to understand the language, it's a really hard sell. So when we go out and we try to find original co-sponsors for the bill, we look at people that are on our committees of jurisdiction. That's the HELP committee or the Ag committee most of the time. So we look to them because they would have policy staff who's working on these issues. So that's our first line. And then you start rippling out from there. But to be very honest, there's issues that if they brought to our office that's outside of food as medicine, I don't know if we would always have a policy expert on our team to really understand this is what's happening and this is what the policy would do. And nobody wants to sign their name to a bill that may have unintended consequences that they can't figure out. Now, we have resources, every office has resources that they can go to get technical assistance to understand it. But by and large, members are going to stick in policy areas that they know best, and they have staff trained and educated in those areas. And so in places like this where we're talking about agriculture, there's fewer and fewer people who have access to agriculture just because of, the loss of agriculture production across our country. And then you talk about healthcare. While there are a good number of senators and representatives who come from a healthcare background, it's not the majority. It's not even probably a fourth. So that barrier right there would really, I think, not scare off, but just cause some members to have pause. And so it's incumbent upon us then to educate them, and that's where the stories come in. Everybody's going to have a similar population to what we're trying to help in their states. So it's getting past the heavy policy, and it's saying, look, we have mothers who, are not getting the nutritional needs. Their nutritional needs are not being met, and therefore we're experiencing low birth weights and, all of the ripple effects of that. Everybody has those people in their communities. And then what you guys can do is take your networks that you have in other states to then take your requests up to your members to help tell this story. And that's really helps when they can connect it back to their constituents.
Great. I promise I'm coming your way, but I'm going to do a quick question to Lauran. Katie had mentioned the Department of Agriculture. So as states think about 1115 waivers, clearly those waivers need to go through the state Medicaid agency. But are there other agencies within the state that are pivotal to helping spur that conversation forward, thinking about Department of Agriculture?
Press the button, it should turn green.
Oh yeah, let's get
Oh my gosh, you guys do not want to listen to me. The technology's telling me to leave. Although I do have class in like 23 minutes. So I do appreciate the flexibility because I got to get to class. So the Department of Agriculture is really key in our state. And I wasn't prepared for this question, but I do have an angle. So as we pursue this Medicaid 1115 waiver, and as we think about what it'll take to persuade leadership, not only elected leaders, but even leadership within health organizations, within healthcare authority, to get them to prioritize this, we've got to think about what is the return on investment. And something that really speaks volumes in a state like Oklahoma is building the local economy. And how do we do that? Well, we support local businesses, we support local farmers. And so something that we really want to make sure that we're incorporating throughout this process is maybe not as much of procuring foods for produce prescription programs that are maybe halfway across the country, but how can we directly work with local farmers so that we're getting true local produce and building that economy in those local towns? And so I can't say that we have the Department of Ag on this group. We do have them on our state obesity plan group. You gave me the idea to do some outreach with them. But I do see a value in having that local ag component. We've talked about it. My co-lead and I just talked about it yesterday via text and how important it is that we instill, regeneratively grown produce, stuff like that. But yeah.
Great. Yeah, I think that's an important component. I think I appreciate you shedding some light on that. That the agencies that we think maybe off the top of our head would maybe move that work forward, maybe aren't the agencies that come to the table first. And so how do we work in that kind of environment to kind of go ahead and move forward with the partners that are interested in hopes of leveraging and building that support with those that maybe will come on later. So appreciate that. Trina, I'm going to turn to you. You always surprise with whatever you're going to present. So I think I'm just going to turn it over to you to deliver all of the special things that you have for us, and noting that you were not able to present the closeout yesterday, so probably extra special.
Oh my gosh, that's a lot to live up to. I'll do my best to both inform and...
3 minutes. No, I'm totally kidding.
So in terms of the perspective I bring, I helped a community-based organization to build food as medicine programs while also wearing the policy hat within that organization. So as director of policy, I helped them look at sustainability. So just a little background for those of you who don't know me. My background is a mix of working in technical assistance and evaluation in academia, and then about 12 years ago, I moved into the nonprofit sector, where I've held a variety of roles that kind of bring together braiding both program and policy work, particularly at the state level. And so the program, the organization I'm talking about is Operation Food Search. They are a rescue food bank that is located in St. Louis, Missouri. They are not part of the Feeding America network and have been around since 1981. I was hired in 2017 to help them implement a new strategy. They were looking at, there had just been a report released, feeding the line or ending the line. I think I heard someone else use that phrase earlier today. And they had created this pillar of innovation. So how do they start working upstream from where they were at as a rescue food bank? Programming was limited to Cooking Matters, nutrition education, as well as being a summer meals provider. So this was completely new territory for them to be getting into policy work. So in that role, Food is Medicine, there was an NPR story. The director of strategic initiatives came to me and said, hey, is this something we could do? And I was like, well, you hired me for policy, and there's a lot of policy implications here, but yeah, this is something that we could do. And so I love creating new things and was able to put together a team to create this Fresh RX Nourishing Healthy Starts program. I was doing it wearing my policy hat, which soon became my policy and innovation hat. And over the 5 years that we built, modified, and grew this program, we grew to a team of 15, a multidisciplinary team that included a really strong state policy element to it. So I'm just going to tell you just a couple quick things about the program and then really get into how this intersects with policy. So these are the enrollment criteria. Putting on my strategy hat in the state of Missouri, we had not yet implemented Medicaid expansion. And when we started looking at this, it was an expensive prospect for our organization. Food is Medicine was not as built out as it is now. We knew it was going to take some investment. And ultimately, as a food bank, we started from a place knowing we did not internally want to try and support that investment financially long term. And so wearing my policy hat, we talked about how we could influence state level policy or relationships with healthcare organizations to get this towards a point of sustainability that wouldn't rest on our development team. The development team was very pleased with that discussion. So we focused on pregnant and postpartum women. I did come from March of Dimes, so I have a maternal child health background. And my thought as I was reading this story about the return on investment for a diabetes education, a diabetes program, Geisinger Health, I'm sure you guys, they've been doing it for quite a while, so a lot of people know about them. But they had this, they reduced healthcare expenses by $24,000 on average per participant. And having just left my March of Dimes hat, I said, we get a 2-for-1 with pregnant women, right? Because not only can we improve their maternal experience, we can also influence the birth outcomes. And so we decided to pursue that. And we specifically decided to look at the most publicly insured population in the state of Missouri, because that's where we thought we would get the most buy-in, and that was women who were participating in the state's Medicaid for Pregnant Women program, which served women up to 300% of the federal poverty level. We went with earlier nutrition, and so we started people no later than 20 weeks gestation. They had to screen positive for the hunger vital sign. We did use the more varianced one, so often, sometimes, rarely, not answering. And then they had to live in St. Louis City or County at the time, because as a food bank, that's where our distribution network was. And so we built a program before the pyramid, the Food is Medicine pyramid existed, and we essentially started with community-supported agriculture, so a combined CSA, so they got local meat, local eggs, local dairy, local fruits and vegetables. But early feedback from our participants told us that they did not have the time, the money, the transportation, the access needed to do the recipes we were giving them, because they required things outside of what was in that basket. And so we then worked with our participants to shift towards implementing. We created the Fresh RX family meal kits. So every week they received 3 meal kits from us. It was enough for a very generous 4 to 6 servings to make 3 meals a day. We tried to make them kid-friendly because a lot of these were growing families. We had several registered dietitians on our team. We had a chef who then went back to school to become a registered dietitian, as well as licensed clinical social workers, because we very quickly realized that the food insecurity was not occurring in a bubble. People had many other issues that they needed help resolving with community resources. So in the very beginning when we looked at this, and perhaps it was my background in evaluation, but I knew if we were going to convince Missouri Medicaid to start funding something or supporting something like this in our state, we needed to start from a place where we had strong data that would help them understand the value of this program to the state. And so while I was recruiting our first licensed clinical social worker and registered dietitian who became the co-directors for the project, I was also interviewing just out there banging sticks together trying to find a health economist who wanted to jump into food as medicine. And I literally, if you're familiar with St. Louis, we have so many universities there. There are plenty of health economists there, but this was not something that they had been approached about before. Finally, I found a team that thought this was kind of interesting, and we came to agreement to work together. So we essentially formed our evaluation and advisory team at the same time we were hiring staff to start building these programs out. And I think that's maybe a little bit different because they played a huge role in helping to determine, we went into it wanting to be able to calculate return on investment and build a program that was scalable throughout the state. And so I would get brilliant ideas and it'd be like, how are we going to do that once we grow outside of St. Louis region? And then it'd be like, all right, I guess I need to calm down. And so we had this multidisciplinary team. We had, I believe, bi-weekly meetings with them. They would come to our conference room. I would feed them snacks out of the warehouse. It was such a hit with the academics. And we would discuss everything from what measures we wanted to utilize to the best way to present this program. We essentially created a randomized controlled trial to implement with this. I can't move forward without saying participant-centered design was at the core of all of this. We had about 10 to 12 moms who were our first round of recruitment, and they made up a participant advisory council for us and advising us as we developed and refined the program, as well as helping us pick the metrics. So we did cognitive interviews with them, which was, I know metrics have come up several times during this conversation, and we never were measuring what we thought we were measuring, or we'd hear that it was too long. And some of these were the gold standards. I believe you brought up the gold standard for measuring food insecurity earlier, Coffee. And the way they responded to us asking 18 items about, they were kind of, and one of them I remember was very vocal and like, why are you in my business like this? And so we spent so long around our measures, and the discussion, we were almost split at the table. The discussion was, do we stick with the standardized measures that are going to help us get this published because they're the ones that we can compare data to, or do we modify these measures to really truly recognize that they culturally, that they are not resonating with our participants, and we aren't really measuring what we want to get at in the core of this program. It was, one of my colleagues from this program is in the back of the room, and it was months of going round and round. I felt a little bit like, it reminded me a little of jury duty, maybe. We were constantly taking votes, like, okay, who feels like we should go this way? Who feels like we should go that way? But I do have to give a shout out to Katie Simpson, if she can wave in the back of the room. She joined my team at OFS originally as an intern getting her master's in social work, and then became a staff member. And she really championed the participant-centered design piece. Sometimes our funders would get impatient with how slowly things were moving, and I'd be like, all right, let's rush, let's make decisions. And Katie would boldly, for an intern, remind me in my position of power that I'd worked so hard to get to, that are we really going to be what we said we were going to be in terms of how we were going to build this, or are we going to rush this along? And so Katie changed my perspective on how I do work, so she's great to talk to. She's probably hating me right now for bringing that up, but She's been amazing to work with and continues to do amazing food as medicine work. So when it came to engaging policymakers, this was part of our decision from the very beginning. We were going to have two targets. The Medicaid managed care companies that were contracted in Missouri, there's 3 under contract at any one time, and our first line was, can we start getting data from them so that we can have this robust randomized controlled trial? And I joked about it yesterday for those of you here. We literally, you could gestate a baby elephant faster than we were able to get data agreements signed with these, and we always were making jokes about pregnancy because, you know, pregnant women and children, it was totally on topic for us. But it literally took more than a year before we could get, it was United Healthcare, Home State Health Plan, which is Centene, and we started with a well care plan that then got bought out by Anthem. And yes, thank you. So we kind of had to, like right in the middle of the discussion, we had to switch. So they were our first line in terms of showing interest in what the potential of this. And so we went to them and said, would you be willing to make referrals of your high-risk pregnancies with the agreement, we're not asking you for any money, we're asking you to share data with our evaluation team. And so it was this bizarre, complicated 3-way relationship between Operation Food Search, Washington University in St. Louis, and each of them. And I'm not kidding, sometimes it had to go all the way up to the national level, right? Like what was going to happen with this data. But that was our first line of like policy defense of where we were going to start. The next was to influence Medicaid policy in the state of Missouri. I don't know what we were thinking there, folks. I'm just going to share that if you guys are familiar with Missouri. Like we expanded Medicaid, but good luck getting your application through. And pregnant women are sort of given more resources in the state of Missouri, but we had meetings with the director of Missouri Health Net, and he'd be like, oh, social determinants of health, there's not enough data on those yet. I think we're gonna hang back before we do move it all. And so we then started targeting our legislature, seeing if we could get them to help us get the Department of Social Services to move. So this is an example of a material that we put together specifically for the state legislators. And what I'll say is they care about something totally different sometimes than our funders do, than the community does, than participants do. We had to make it about the bottom line. And that doesn't always sit well with me because in my heart of hearts, I want to do what's right for people. And sometimes what's right for people and what people will pay for are two very different things. They don't always measure up together. But we started creating materials that we thought would resonate with them. And so this is the front, just kind of outlining for them what the issue was. And then when you went to the back, we did a pilot with 75 participants from one hospital system. And we started looking at the data in terms of reducing food insecurity, reducing rates of maternal depression. I can't even read my, how many healthy babies we had versus what the data was showing us. And cost savings. And then even more compelling than these outcomes, which they cared about, but it wasn't really their language. Their language was, how much money can this possibly save us? And so from our 75-person pilot, we were able to work with our health economist, love Dr. Stephen Roll to my dying day, and really calculate out just from our pilot how much money could we have saved in the city of St. Louis, and what happens when you start extrapolating that out to talk about your state. And so we found the best way to engage, and I've shared this with Elizabeth, and I think she's tried it out. We started going to the Capitol on a regular basis and setting up in our rotunda. You can reserve tables there. I would bring the whole crew. Here I am with short curly hair because it changes anytime I want it to. And we would bring our dietitian and our policy folks, our program people, our director of strategic initiatives. We would send out invites to everyone in that in the entire building to come see us. We would do recipe demonstrations for them of the recipes that were going out to families. We are positioned in this place right outside the Senate floor and the House floor. We always cooked onions, you guys, because they would get hungry in the afternoon, and they said they would come out and say, what is this delicious smell that's reaching me on the House floor? And so even against their will, because they didn't always want to interact with us because they knew we were asking for something, but the food would lure them out. And we would have this flyer out there. We would have their legislative aides and chiefs of staff coming. We always did a savory and we always did a sweet. And we had enough people there that they could not just walk up and get a little sample cup for us. We were on them. We were on them, and we stayed on them until they went back into the chamber. So we were having conversations. We used locally grown ingredients, and we would talk to them like, oh, Senator so-and-so, we're using rice this week that was grown down in your district. What would happen if we could make this larger? What would happen if we were buying rice to feed all the pregnant women all of Missouri? And they engaged around it, right? We took like an agricultural angle to this. Like, not only was it Medicaid spending, which is not their favorite thing to talk about, but how does this strengthen the agricultural system, which is the biggest economic driver in Missouri? We had amazing conversations. They would come up and say, hey, I have a source of funding for you. Why don't you apply for these state dollars? We formed such amazing relationships across the aisle because we could find something to talk about that resonated with every single person. We did this program for 5 years. We started a randomized controlled trial. And I think one of the questions I was asked is kind of, where are we now? And I am sad to say that after 5 years, I left the organization, as did Katie. We were burnt out. And that's nothing against the organization. I think watching a big organization pivot from being what they have been for a very long time to wanting to take on a new persona, there was a lot of inner conflict with what that required of the organization, along with the fact that we were fighting against in 2017. The people were not familiar with it, right? So when we went to health systems, they didn't really know how to integrate us into this. We also tried to do everything internally ourselves. We were like a one-stop shop for people to contract with. And so unfortunately, the program doesn't exist in the same form anymore. But I feel like, should we have had the fortitude to stay for a few more years, we were making progress towards really seeing this become something that had state level support.